I saved a difficult question for Farshid. So, Durvalumab and immunotherapy, this is not the first immunotherapy was studied in that setting, right? We had a study with pembrolizumab. What are your thoughts on just
I think
one IO positive, one not? Sorry, go ahead.
Sam did a great job showing the graphs next to each other, exactly the same hazard ratio, same separation. It's all just how you do the math, right? So to me, none of the trials was negative. There's a common sense approach, and the clinical significance and the p-value. And this time it was the other way around, right? Usually we say they're statistically significant, but not clinically. I think both trials were clinically significant. I think, as Sam also pointed out, if they had chosen to give FLOT to all the patients, maybe that would have made actually a big difference. So when we compare cross with FLOT, we should not compare apples to oranges. If we say it's frail, the patient can't take it, that patient wouldn't have gone on the cross trial either. So we are talking about a fit patient who's supposed to go to surgery. That primary tumor is coming out. So it never made sense to me to think what's the role of radiation. We actually, with DFLOT, get responses as quickly as with radiation. And as Philip said, we can put in stents, we can in feeding tubes. Controlling the metastatic disease, that's what makes these patients live longer. So better systemic treatment earlier with the primary tumor in place is going to improve outcomes, as we saw, I think. It's a bit, I don't know if it's fortunate or unfortunate that one trial was positive, one negative, but if you just look at the outcomes, they're so confirming each other that the principle is your best systemic treatment up front. Now the question is, how do we agree and accept that we give poor patients post-Whipple 6 months of FOLFIRINOX, but after 4 cycles of FLOT, we make a stop and say, oh, they can't take it anymore, right?
I think there's more than in frailty. I think we all get biased also when we look at the pathology, right? When we see a pathology report and we have no treatment response, 12 positive lymph node, and a patient has lost 10% of the body weight, it's just hard to justify to give more FLOT. I'm sure we all struggle with it. I don't know, does anybody want to comment on what is the approach, and should we just give Durva in this situation?
No. For the way we understand the data, so that's where we're so happy MATTERHORN confirmed us, is actually we front-loaded, right? If only half of my patients will get FLOT afterwards, and it's working, and I have now means to measure that response up front, I front-load it.
You mean you give all cycles?
TNT. And if they don't get 8 cycles, maybe the last 2 cycles, there's no taxane in there.
Tough patients in California who can tolerate 8 cycles of FLOT.
But we try to maximize the pathologic complete response. And I hope then with adjuvant Durva, and I hope that we over long term increase the tail by if it works, and I'm going to give 8 cycles anyway, and I know after surgery, there is a delay in between where the metastasis is still growing, and it's going to be more difficult to tolerate it. Why don't we try to do a TNT? And I wish that was part of the discussion yesterday. It's like we do it with all the other GI cancers.
What is your thinking of TNT, Vince? The other coast.
Yeah. I share your reservations, Natalia, and all of the California patients. I mean, I think, in our experience, just FLOT itself can be challenging for patients, and the idea of front-loading all the cycles, I think, would cause some heartburn for some of our surgeons. But I mean, I think the concept is spot on. I mean, I think what we're learning through and through, not just in upper GI, but in other tumors, is that, especially node positive but locally advanced gastroesophageal cancer is a metastatic disease. And so the more effective metastatic systemic treatment we can give, that probably pushes the survival curve.
Yeah, the TNT, I hear you, and it's nice on paper, thinking about it, but you have to think of the patient. A lot of patients cannot continue easily that long. And in fact, there is probably a threshold of treatment that beyond that, it doesn't really matter. 8 is not like double 4. It's double, it's times 2, but at the same time, biologically, it may be only 0.025 more.
I fully agree, and that's why I think if you give 6 and the last 2, you just let them slide with a little bit of Durva 5FU, probably you get still the benefit without the toxicity.
I mean, there was a recent analysis in pancreatic cancer. If you give 8 cycles, not 12, then you don't need additional 4 cycles, which we do. So one has to be careful because the 6 months or what, these numbers are arbitrary. But if you throw it in upfront with immunotherapy, you may not need to give 8 cycles, and you might be done.
I think it's an unanswered question. Maybe another clinical trial will help us answer this. I think, in my experience, it is hard to give more than 4 cycles without dose reductions. And so once you start to reduce the doses of chemotherapy, the question is, does it make sense? I do stick usually to 4, occasionally give the 5th cycle if there's any delay with surgery. What do you think, maybe I'll start with you, Jun. What do you think about PD-L1? PD-L1 has established itself as a biomarker in metastatic disease. We know IO doesn't work in tumors with PD-L1 CPS or TAP score less than 1. Here we've seen maybe it's slightly different results. What is your take? Are you testing for it?
We are testing for it because a lot of indications, FDA indications, at least in the metastatic setting, depend on it. But everyone on this panel would know PD-L1 is such a controversial marker. When we speak to our pathologists, it's really, they have confidence in it being negative or positive. Right. But to get a value of 5, 3, it's virtually very difficult. And so I think there is improvements for it, but it's the best we have right now to guide some of our indications in the systemic setting.
But at least in MATTERHORN, it looked like PD-L1 maybe mattered less. Small percentage of patients were negative. Curious to hear the panel's take on this.
10% were negative.
Yeah. Right, 10%, exactly. Yeah.
Just really wide confidence intervals. I'm not sure we can actually make much about that. I definitely wouldn't use that subgroup analysis to say that we should not give MATTERHORN to our PD-L1 negative patients.
I wanted to follow up on an area which is clearly outside of my expertise, which is always a risk, and I love my pathologists, but when you read an IHC-based assay, especially if it's percentage and plus something, there's error in reducibility. So the issue is that we have a test, and we have the best we have, that we're making major treatment decisions on, which certainly is not 100%. It doesn't represent how you break down a continuous variable in a categorical way. But on the other hand, as many of us know, the combination of the data in recurrent metastatic disease is similar across trials. So I'm curious, though, as the way things developed in advanced disease, and eventually we synthesized, thank goodness, because I can't remember cutoffs very well, to 1. That happened after we accumulated additional trial data. So, but for now, I would give it to everyone.
Yeah, I mean, the downside of ignoring the low value or the 0 is that you may deprive a patient from benefit. Because unlike DNA markers that are more black and white, IHC markers are dependent on how long the specimen stayed on the bench, or who read it, and the light, and different things. I mean, one thing which I was also going to bring up is with the issue of the 8 cycles you wanted to give and all that, is what a ctDNA guided thing one can do. Whether you give, if you give 4 cycles, 4 to 6, and then ctDNA is cleared, you're better off. But then again, what do you do if after 4 or 5 cycles the ctDNA is up?
I can refer you to our trial that hopefully will open very soon. We did published in Future Oncology. It's called the RANT-GC trial, risk-adapted neoadjuvant therapy for gastric cancer, where we address exactly that question. If there is no ctDNA response, we will switch to a different regimen to get the response before you take because doing the wrong thing and expecting that's because it's standard of care, as Nataliya said, giving just 4 cycles without any evidence of response, goes to surgery, 0, and then I give the same thing again. I think we need to move away from that.
The reason why I brought up the ctDNA, and I didn't want to diverge the discussion, but it was in relation to the PD-L1. Now we're giving the whole treatment, we are constructing the whole treatment longitudinally on a PD-L1. But if we have a more dynamic way of looking at it, I mean, people looked at PET scan, for example. If we have a more dynamic biologic evaluation, then we might change the course during the treatment.
Yeah, if I recall, I think it was CLGB8, I'm not supposed to quote, 80803, where they used PET. This, of course, was not perioperative chemo, and they did see a difference with switch.
Based on the PET response, slightly different. And Yeah, but kind of tells us that we need to incorporate tumor biology into treatment selection. Not everybody's going to respond the same.
Yeah.
Hard to quote the statistics to patients. Patient asks me, what is their prognosis? Are they going to, what's the cure rate? And I actually, my answer usually is we'll know more once you go to surgery and look at pathology, because really that tumor downstage and lymph node positivity is more telling in terms of tumor biology.